Hello, everyone. Thank you for joining us today. My name is Tage, and I am an inquiry specialist for the Snowflake's Embryo Adoption Program. I also work with the Embryo Adoption Awareness Center, which is a resource center that brings awareness and resources to families considering embryo donation and adoption to build their family. Today, we are going to speak on a topic that at times is treated with much stigma and taboo: mental health, specifically disorders like schizophrenia and bipolar disorder, and how these conditions may affect your embryo adoption journey. Joining me today is Megan White from Nightlight Christian Adoption's Florida office, where she's the executive director. She has 30 years of experience in the mental health field as a licensed clinical social worker. She also has experience in psychiatric hospital settings, intensive outpatient and private practice settings, and in the adoption field. She's going to speak with us today about schizophrenia, bipolar disorder, and how these conditions may affect your embryo adoption journey if you are matched with a family who might have a history of these mental conditions or other mental conditions. So thank you so much, Megan, for joining us today.
Paige, thank you so much for having me. I look forward to talking about this topic, as I really think this is important to consider, as millions of people, including embryo donors and their families, are affected by mental illness. First of all, millions of people, including embryo donors and their families, are affected by mental illness. In fact, 51.5 million adults experienced mental illness in 2019. Even with the prevalence of mental health conditions, people tend to fear mental illness or view them in different classes than other diseases. Mental illness is a disease of the organ of the brain. Just like any other organ in a body might become diseased, the brain can as well. In my experience, people generally view diseases from the neck down with less stigma than those diseases from the neck up. So diseases affecting the brain can tend to be misunderstood or even feared. With education and understanding, thankfully, this misconception can be changed. Currently, there are many excellent medications and therapy treatments to help those with mental illnesses to live healthy and productive lives. 3 things to consider when considering mental health of donor families would be that embryo donors may have identified mental illnesses in their medical history, that research has demonstrated that there is no one single cause of mental illness, such as one gene passing bipolar disorder or schizophrenia to the next generation. And historically, overdiagnosis and misdiagnosis have been common. Gaining an understanding through education will help lower the mysticism and fear associated with these mental disorders and adopting embryos. All right, let's look first at the history of diagnosing mental illness. To understand the diagnoses of mental illness over the years, it's important to know the history of the profession of psychiatry and diagnoses of diseases that have progressed over the years. You may be considering adopting embryos from genetic parents with a family mental health history of bipolar disorder or schizophrenia. As you look at the medical history form, please consider the ages of the people diagnosed and the degree of relation to the genetic parents. Ask yourself, what was the relation? Was it a grandparent or a great uncle or aunt? Mental health diagnoses and treatments for the diseases have greatly improved over the past 40 years. To give some history, the US Census began collecting basic data about mental illness in 1840. The first standardized book was the Statistical Manual for the Use of Institutions for the Insane, which didn't appear until 1918 and was specifically used to collect data for patients in mental health hospitals. It did not guide the treatment of mental illness. In the early 1950s, psychiatrists assembled a manual that would help community-based doctors to classify the mental health disorders that their patients were presenting with. This book was called the Diagnostic and Statistical Manual of Mental Disorders, or DSM-1. Only slightly over 100 mental health conditions were listed, and most were described in very short 2 or 3 sentence definitions, and definitions were very general. The focus of the majority of psychiatrists in that era was doing psychoanalytic talk therapy, which is therapy based on the ideas of Sigmund Freud. Diagnosis was not the primary center of attention. Researching disease symptoms and understanding the biological component of mental illness wasn't a focus and wouldn't be for many more decades. When the second Diagnostic and Statistical Manual of Mental Disorders, or DSM-2, was published in 1968, it continued to have short, general descriptions of mental disorders. But soon after the DSM-2, psychiatry began to undergo dramatic changes. Research showed that psychiatrists were unable to measure even the most fundamental conditions, such as schizophrenia and manic depression. What one doctor called schizophrenia was often called manic depression by others. Diagnosing mental illness at the time was very subjective and led clinicians to rely on their own intuitions about what condition they were treating. In the 1960s and 1970s, psychiatrists focused on disease biology, which emerged and emphasized understanding brain function. They focused on the need for careful definitions of each mental disorder. Psychiatry became more research-oriented and biologically grounded in the 1970s, and it was clear that the DSM-1 and DSM-2 weren't suitable anymore to diagnose and classify mental illness. Also at this time, medications to treat mental illness became the first response to treat mental illness. Understanding grew that different drugs targeted different forms of mental illness. In 1980, the DSM-3 was published and replaced the DSM-1 and 2. This edition of the Diagnostic and Statistical Manual of Mental Disorders featured precise, symptom-based classifications used to understand and properly diagnose mental disorders. Statistical Manual of Mental Disorders, 5th edition, or DSM-5, published in 2013, is used by mental health professionals to diagnose mental disorders. Although the classification of mental illnesses has changed drastically in the last century, society's understanding and beliefs about the illnesses have been slower to evolve. First, we'll talk about schizophrenia and schizophrenia spectrum disorders. First, schizophrenia is considered along a spectrum of disorders. The spectrum of disorders is organized along a range from mild to more intense psychopathology. The diagnosis of schizophrenia requires the exclusion of another condition that might lead to psychosis. Disorders included in the spectrum include and describe mental illnesses that may have been misdiagnosed as schizophrenia prior to the DSM-3. These include delusional disorder, brief psychotic disorder, schizophreniform disorder, schizoaffective disorder, psychotic disorder due to another medical condition, and substance medication-induced psychotic disorder. In fact, studies show that between 7 and 25% of individuals presenting with a first episode of psychosis are reported to have a substance or medication-induced psychotic disorder. And despite high rates of relapse, for most individuals, outcome is excellent in terms of social functioning and symptomatology. The symptoms of schizophrenia involve a range of cognitive, behavioral, and emotional dysfunctions. No single symptom indicates that a person has the disorder. The diagnosis involves the recognition of a grouping of signs and symptoms associated with impaired occupational or social functioning. There are currently no radiological, laboratory, or psychometric tests for schizophrenia. According to the DSM-5, the diagnostic criteria for schizophrenia is 2 or more of the following, each present for a significant portion of time during a 1-month period. Delusions, which are false beliefs that are not based in reality. Hallucinations, which are usually involving the hearing or seeing of things that don't exist, but have the full impact of being real to the person. Disorganized speech, which due to the person's disorganized thinking, effective communication can be impaired and their answers to questions may be partially or completely unrelated. Extremely disorganized or abnormal motor behavior, which describes behavior that's not focused on a goal and it's difficult to accomplish tasks. And then lastly, negative symptoms. This refers to a reduced or lack of ability to function normally. For example, the person may neglect personal hygiene or appear to lack emotion. They may lack eye contact, they don't change facial expressions, they may socially withdraw and lose interest in everyday activities. For a significant portion of the time since the onset of the disturbance of schizophrenia, the level of functioning in one or more areas such as work, interpersonal relations, or self-care is significantly below the level achieved prior to the onset. And continuous signs of the disturbance persist for at least 6 months. Other mental disorders with psychotic symptoms have to have been ruled out, and the disturbance can't have been caused by the effects of a substance like a recreational drug or a medication or another medical condition. I'm sharing the diagnostic criteria of schizophrenia with you today to highlight the specific features that must be met in a certain period of time, lasting a certain period of time, for an individual to be diagnosed with schizophrenia. Other mental health disorders must first be ruled out, and the condition cannot be because of the effects of a substance or other medical condition. The onset of the psychotic features of schizophrenia typically emerge between late teens and the mid-30s. Onset prior to adolescence is rare. The peak age at onset for the first psychotic episode is in the early to mid-20s for males and in the late 20s for females. The onset of schizophrenia may be abrupt, but the majority of individuals manifest a slow and gradual development of a variety of clinically significant signs and symptoms. And I want to emphasize here the importance of early detection and treatment of the illness, which leads to better clinical outcomes. The lifetime prevalence of schizophrenia appears to be approximately 0.3% to 0.7%, which equates to less than 1 in 100 people who will develop schizophrenia. Said another way, 99% of people will not develop schizophrenia. Now we're going to talk about bipolar and related disorders. Diagnoses included in bipolar and related disorders are bipolar 1 disorder, bipolar 2 disorder, cyclothymic disorder, substance or medication-induced bipolar and related disorder, bipolar and related disorder due to another medical condition, other specified bipolar and related disorder, and an unspecified bipolar and related disorder. The current bipolar 1 disorder criteria represents the modern understanding of the classic manic depressive disorder. A large number of substances of abuse, some prescribed medications, and several medical conditions can be associated with manic-like phenomena. There are currently no specific blood tests or brain scans to diagnose bipolar disorder, and no single test will confirm the disorder. A doctor should perform a physical exam and order lab tests to rule out other conditions or factors that might be causing the symptoms. With diagnosing bipolar 1 and bipolar 2 disorders, it's important to note that a person with bipolar 1 disorder has had at least one manic episode in their lifetime. Many people with bipolar 1 disorder also suffer from episodes of depression, and often there is a pattern of cycling between experiences of mania and depression. In between these experiences, many people with bipolar 1 disorder and bipolar 2 disorder can live normal lives. With a manic episode, a distinct period of abnormally and persistently elevated or irritable mood is present, and increased activity or energy lasting at least 1 week and present most of the day. And this causes significant problems socially or at work and may require hospitalization. In contrast, a hypomanic episode is a distinct period of abnormally and persistently elevated or irritable mood and increased activity or energy, lasting at least 4 consecutive days and present most of the day. This is not severe enough to cause marked impairment socially or occupationally. And a major depressive episode is characterized by persistently depressed mood or loss of interest in activities, causing significant impairment in daily life. And these symptoms must last at least 2 weeks. So symptoms of a hypomanic or manic episode include high self-esteem or inflated self-image, decreased need for sleep, rapid, pressured, and loud speech, flying suddenly from one idea to the next, getting easily distracted, an increased interest in goal-directed activity, either socially, at work, at school, or sexually, or psychomotor agitation, and excessive pursuits of activities with a high risk of danger or that have high potential for painful consequences, such as unrestrained buying sprees, hypersexuality, or foolish business investments. The age of onset of the first manic, hypomanic, or major depressive episode is approximately 18 years for bipolar 1 disorder. Although bipolar 2 disorder can begin in late adolescence and throughout adulthood, average age of onset is in the mid-20s. The illness most often begins with a depressive episode and is not recognized as bipolar 2 disorder until a hypomanic episode occurs. Speaking of prevalence, the 12-month prevalence estimate in the continental US was 0.6% for bipolar 1 disorder. Bipolar 1 disorder is more common in high income than low income countries. And the 12-month prevalence of bipolar 2 disorder in the US is 0.8%. These statistics equate to less than 1 in 100 people who will develop bipolar 1 or bipolar 2 disorder. And said another way, 99% of people will not develop bipolar 1 or bipolar 2 disorder. So, mental illness and genetics. Does bipolar disorder or schizophrenia run in families or emerge fully formed out of nowhere? This question has consumed theorists, therapists, biologists, and geneticists for generations. Researchers suggest that genetics and the environment might interact with each other to produce the symptoms of schizophrenia and bipolar disorder. Researchers have recognized the need to build a bridge between understanding the two ideas of environment and heredity. Like many illnesses, a family history of bipolar disorder or schizophrenia is a risk factor for the development of the disorders. The magnitude of risk increases with degree of kinship. However, research shows that there is not just one gene that is responsible for the cause of mental illnesses, such as bipolar disorder or schizophrenia. In fact, research argues that schizophrenia and bipolar disorder are most likely caused by not just one gene, but multiple genes working in tandem with, or possibly activated by, environmental factors. According to the DSM-5, most individuals who have been diagnosed with schizophrenia have no family history of psychosis. Now let's bring this back to how this applies to your own embryo adoption as you're considering adopting embryos that may have a genetic history of a mental health condition in the genetic family. Okay, so what should you take away from this? There is not one specific cause identified for mental illness. There are some genetic risk factors, but research demonstrates that there is no one specific gene that is responsible for mental illness. A variety of medical conditions may cause psychotic symptoms and manic, hypomanic, or depressive symptoms. So it's important to consider this as you're looking at the family history of the genetic parents If there was a grandparent or a great-grandparent diagnosed with schizophrenia or manic depression or bipolar disorder, this could have been a misdiagnosis if done prior to the publishing of the DSM-3. Conditions such as neurological conditions, MS, epilepsy, delirium, migraine, and even electrolyte imbalances could have caused some of these psychotic symptoms that might have actually resulted in a diagnosis. It's important to know that millions of Americans live with mental illness, but there is so much hope for individuals with mental health disorders. There's new treatment options, including medications and therapies that are being developed consistently, and many have positive outcomes for patients. Most importantly, early detection and treatment for mental illnesses are crucial to positive outcomes. Thank you so much for attending today, and I hope you gained a lot of information as you're considering the background of the genetic parents and mental health issues.